Hello. So I'd like to talk about my favorite patient, Mr. J. He came to the skilled nursing facility that I was at after a fall that resulted in him being on the floor for over 13 hours. He lives alone in a rural area, and it was a passing neighbor that heard him hollering for help. And then, yeah, eventually he had a hospital stay. I think it was 3 days. And then we got a hold of him. So, as complex patients go, Mr. J, 67-year-old male, Parkinson's, a COPD with pretty severe orthopnea. He had to live in like a high Fowler's position, clinical depression, CKD, obesity, opioid addiction, and complex or complex renal pain syndrome. Yeah, when he showed up, his MMTs on average were like 3 plus for lower extremities, especially on the left side. He his gait didn't look. It made me nervous just watching him walk. He suffered falls quite a bit, I guess, at home before the big one that had him stuck on the floor. And it made sense once we saw what his gait looked like, why he was falling all the time. The walker would get so far out in front of him, and his feet just were not keeping up. His walker was too high. It needed to be a little lower. And yeah, that was kind of the part that I was the most proud of. If I can jump to the gait training, he loved the movie Rocky, and there's a scene where Rocky has his ankles tied together by his trainer so that his footwork improves. And I had him pretend that Rocky's trainer had tied his four-wheeled walker to his gait belt, so he couldn't break the string. And that's what we would play. We would play "Don't Break the String" when we were working on gait training, and it wound up working. That just seemed to click with him, and then he was able to keep the walker closer, and then kind of once we had a connection going, we were able to kind of bit by bit improve chunks of his gait training. If it was lifting his feet a little bit more, it helped with the auditory cues about cueing him in to listen for the shuffling of his feet. So lots of cueing about like, don't break the string. We don't want to be able to hear the feet. Try to stand up nice and straight and tall. And then after a while, it started to get habitual. And his gait, I mean, eventually he was cleared for in-room mobility. So his breakdown once he got to us, his body structure function, according to the ICF model, BLE weakness, rigidity, severe orthopnea, shortness of breath, kyphosis, allodynia, impaired balance, bilateral glute rhabdomyolysis after the 13 hours on the floor. And then his activity limitations, he was Mod A for bed mobility, also Mod A for wheelchair to bed, bed to wheelchair, and then wheelchair to toilet, toilet to wheelchair. And then he was CGA Min A for gait. And then his participation restrictions, he didn't really want to participate because he didn't think that he belonged there. He didn't want to be seen in a wheelchair because he was used to walking everywhere. So he would take his meals in his room, and he wouldn't go to bingo or anything. Once he was able to start walking more, then he started to show up to bingo, and you'd see him in the dining room. That was really cool. And then let's see, personal factors. He did struggle with impulsivity, and he was sometimes inappropriate. yeah, loved the movie Rocky. And there were some familial issues afoot. He was estranged from his other son that was still alive, and his pretty much all friends and family except for his older sister, who cared for him sporadically. Yeah, and then environmental factors, lived alone, one-story house in a rural area. So then the evaluation and interventions. Talked about the gait training, strength training, lots of sit to stands, heel raises, toe raises, leg lifts, straight leg raises, marching, squatting, glute bridges, pull to stands, using the rail in the hallway. Notable improvements in everything except for toe raises. His calves would spasm quite a bit. He loved the manual therapy. My massage background actually came in really, really handy. I think that's what early on kind of helped us establish a bit of a connection. That and Rocky. A lot of functional bed mobility training and balance training, tug, parallel bars. A lot of perturbation training seemed to help elicit his, like, a delayed ankle strategy. Initially, we had no ankle strategy. It was always step. I never really was able to get a hip strategy out of him, strangely. But we were able to get some traction with the ankle strategy a little bit. And then discharge plan, by the time my rotation was up, we didn't really have one formalized yet, but my CI and I had agreed that, assisted living would make sense. My reflection, him and I had a great connection. He didn't really seem to connect with the other staff, but for some reason we clicked, and I was able to get him to work. And it was really cool seeing him improve.